Good evening. On behalf of the Indian Chamber of Commerce, it gives me immense pleasure to welcome you all to today's session. The pandemic suddenly swept us off our feet, and the world is definitely not what it used to be. As they say, this is the new normal, and probably it is here to stay, at least for some time. So, how prepared are we to face this sudden crisis? And what is the way forward? We have with us this evening a very erudite and strong panel to share their thoughts on the subject. Our moderator for this session is Dr. Rupali Basu, co-chair, ICC National Expert Committee on Healthcare. He's the CEO and director of Woodlands Multi-Speciality Hospital, Kolkata. Welcome, Dr. Basu.
Thank you.
We are privileged to have with us Mr. Rajiv Sadanandan, former Additional Chief Secretary, Government of Kerala, and CEO, Health Systems Transformation Platform of India. Welcome, sir. We have with us Dr. Giridhar Babu, Professor and Head of Life Course Epidemiology, Public Health Foundation of India. Welcome, Dr. Babu. Dr. Tyagarajan Sundararaman, Global Coordinator, People's Health Movement, India. Welcome, Dr. Sundararaman. We have with us Dr. Ramakant Deshpande, Director, Asian Cancer Institute, Mumbai. Welcome, sir. Mr. Joy Chakraborty, Chief Operating Officer, PD Hinduja Hospital, Mumbai. Welcome, Mr. Chakraborty.
Thank you.
And our very own Dr. Kunal Sarkar, Senior Vice Chairman and Head of Cardiac Surgery, Medical Super Speciality Hospital, Kolkata. Welcome, Dr. Sarkar. I would now request Dr. Basu to please take the discussion forward. Dr. Basu.
Thank you, Shujoy. Thank you so much. A very, very warm welcome to all the participants to today's very important discussion on ICC webinar on pandemic. And I think a very, very warm welcome also to all our brilliant, renowned speakers who are with us. Very, very important panel. We would like to listen from each one of them and we'll take down our notes. And that's how we will move ahead with this webinar today. I have been working in healthcare for last 25 years and it's been, getting into the hospital, you see a crowded lobby, you feel so good. I have heard Dr. Pratap Reddy, whom I have worked with for 15 years, also keep saying that Rupali, the lobby is full, I feel so great. But today, after 25 years of working, I don't think I'm very happy to see a crowded lobby. Me as a leader, I have always seen that leave application, I hate it. I don't like leave applications. You have to be physically there, work for 10 hours, 12 hours, 14 hours. I don't want to see your leaves. Today, I'm okay with people working from home. 50% of my staff, the hospital is running full, but they're all working from home. They've got different kinds of schedules, rosters, all kinds of things, and I'm accepting. Doctors, any movement with the doctors with hand hygiene and hand washing would have always failed. They always say that, nothing will happen to us. Nothing happens to doctors. But today, those doctors are changed so much. They're doing so much of hand washing, looking into their protective equipments, and actually quite in scare, quite worried that how they're going to work in the future. And of course, currently. We as Indians, I don't think we are too great in rule followers or being civil to the other person or being sensitive. In many a times we are not. But look at us, look at all Indians today. We are following, most of us are following laws. We are locked down, we are being sensitive to others' needs, and we have been civil. I think if this is the country that we will emerge post-pandemic, then I will be very happy with Indians. But with these changes, the biggest change which is bringing all these changes is the pandemic itself. And let's go ahead with the panel, with the opening remarks from each one of them about what has happened in the pandemic, what is going to happen in their own words. So we start with Mr. Rajiv Sadanandan. Sir, with you, the opening remarks. How do you think the pandemic has fared? What we should do, and how we should move on? What is your original thoughts? About 3 minutes for you. Shuman, you have to. I think you have to audio on.
Okay, right. When I look at this whole pandemic, what I feel sorry about is the opportunity that we missed. Unlike many of the viruses, this virus, I would say, was kind to us. It gave us almost 3 months notice. It demonstrated for us what is going to happen if we don't act. And because we knew where the epicenters were, all we had to do was to track the people who were coming in. And that was also available from our immigration departments. And if we had a health system that knew how to identify the people, how to track them, how to trace their contacts, and how to quarantine, many of these issues could have been avoided. And we have Kerala that demonstrated how it can be done. I agree, Kerala was lucky in the sense that, not lucky, that's not lucky, in the sense that they had dealt with a severe epidemic before and had twice and had been trained on how to trace and track, how to quarantine, how to follow the rules of epidemiology and so on. And but this is something the rest of the country could have done. So anybody who has been watching this, and in this panel there are people who know epidemiology much better than I do. Anybody who had ever tracked an epidemic knew what was going to happen, and we didn't do it. We waited for 3 months and then used a strategy that is generally kept for the last, which is a kind of which is a lockdown, without taking any of the other precautions. So what happens is, because you're not done the proper prevention measure, by the time you've done your lockdown, the virus is already in the community. It's already circulating within the community. So what do you get? You are able to prevent transmission going from one cluster to the other. But those clusters that are already infected are going to have the virus circulating and so on. And also gives you a false sense of security that disease prevention is hard work. You have to, the leg work, the follow-up and all have to be done. I suspect, when I look at the numbers that is happening post-lockdown, that work was not done. Otherwise, we shouldn't be seeing the kind of cases going up like this. Again, as the epidemiologists warned us, the only thing that lockdown does for you is it buys you time. With no herd immunity, no vaccine, the curve can be made smaller and stretched longer. And that is of no use unless we made use of the opportunity, the time that lockdown gave us, one, to improve our prevention measures, and two, to improve our surge capacity, which is if the spike goes really high, do we have enough beds? Do we have enough ventilators and so on? I hope, and because most of this happened at the state level, and that's a very, very refreshing thing that has happened, most of the responses have been driven by local authorities. And I guess that the response of different states are going to be different. I hope that across the country, people have gone back to the basics and use the lockdown, one, to take whatever prevention measures could have been done, and two, to prepare for the hospital capacity. Going forward, at this rate, if the epidemic keeps going up, we might just have delayed the spike. And I hope the capacity is in place. I'll stop with that.
Mm-hmm. Okay, so why don't we come to Joy, Mr. Joy Chakraborty from Hinduja Hospital? Your opening remarks.
So I have something to say from the macro level, of course, what is happening in the country. And also I feel, envy of Dr. Basu that she is getting hospital full of patients, but In Mumbai, it is absolutely a different story altogether. Here, employees have been, asked to come to the hospital, but hospital occupancy utilization has gone down drastically, and I need not to tell the
No,
reason.
the same scenario here too. It's just that very recently there is a spike of occupancy because we have been able to do something after the 30th circular. So that's the only. It's the same. All hospitals are empty. Yeah, Joy.
So that is something. But now, if we tell that how we are faring, and as I heard from Mr. Sadanandan, I must say, very recently, and one of the person who has been featured there in the latest Lancet of May 2020, he is also here. I want to tell very nicely, the author Patralekha Chatterjee in May 2020 Lancet has written that in India, what is not going well, what is not going well, that is our public health system is not probably sufficiently geared up to manage the situation. Why it is not geared up? Because of course all of us we know the kind of GDP expenditure is made for the healthcare, but probably one of the very important reason is the trust factor. And as Mr. Sadanandan told, that initial things could have been stopped in the level of immigration. But even if I take that we have missed there, and the next level, we are doing the cluster containment, like, identifying people, taking them to contain, quarantine area or isolation centers. Many of the people have started leaving from there, and that is because of the fear factor. They started feeling, is it the right place for me to be there, or should I go somewhere else? Or sometimes it has happened that they don't want to follow the rule. And if that happens, then it becomes very difficult for any government to manage this scenario. And when we are standing today close to 66,000 cases, out of which, of course, several thousands have recovered and have gone home, but there is a wide variation amongst different states and cities in terms of the plan, the way they have planned for their surge capacity and strategy, which is leading to a situation probably that some of the places are getting badly affected. And we have seen a scenario of Kerala where they could manage to flatten the curve, whereas a similar kind of populations-based state couldn't able to do that. So it raises some of these questions, but probably what we need to have a good private public partnership, getting everybody together and making them part of this journey, and probably that can give us some sorts of relief at the end of the day.
Mm-hmm. Okay. So we move to Dr. Babu. Should we get your opening remarks now? So we got the Kerala perspective from Mr. Sadanandan. We got a Mumbai perspective, not really detailed, but some from Mr. Chakraborty. But your opening comments, Dr. Babu.
Yeah, so I would mostly restrict my comments to epidemiology and the public health aspects of this. As of today, we have nearly 67,000 cases. But in India, what is heartening to see, and I say heartening because there were doomsday predictions in terms of India will not be able to match the kind of cases, and we are going to have several deaths compared to what those predictions were. Even when people are saying that there is increase in number of cases in the last 2 weeks, the doubling time, what we measure in epidemiology, has increased. If you compare it to earlier, it has increased from 6.7 to 7.6 days. And the RO, which means that how many people does one person can spread, has decreased from 2.08 to 1.84, which means though the absolute numbers are increasing, it is still much lower than the exponentials that we see anywhere else in the world. So why? That's a different question altogether. We'll come to that by several explanations later. And again, there's some myths around the facts that we see and how we report. Generally, there is a fear whenever there are more cases. But I think we should move away from that. My fear is when there are no cases and there are states where cases have been picked very late. and the first case was notified by a death. When there is a death, there are already 100 infections or more which are there in the community. So therefore, more cases is always a better thing to begin with, because just to give an example, Kerala had the highest number of cases for a very long time. When people were debating why Kerala has so many cases, they did it because they had good surveillance. And today, the entire world is hailing Kerala as a best model to emulate. So we should move this fear that cases is a bad thing. What is bad is the mortality associated with it and why it is. And there are reasons. And I'll explain probably if I get a chance later. But to prevent deaths is the focus. The only way to prevent deaths is to identify all the people who have infections. So when we start looking at people, how the states are performing, again, the focus is on Maharashtra, saying that there are many cases there. But there is an indicator that we need to see called as test positivity, which means among those whom you tested, what is the proportion of people who turned out to be positive? In this country, the highest test positivity is in Maharashtra. What does it mean? It means that probably they are testing the right kind of people who might have the infection. This is followed by Chandigarh, Delhi. And somewhere middle and much lower is, as the number of tests is increasing, the test positivity is going down in some states. That means we probably are randomly testing people and therefore it is falling down. That doesn't mean that the infection has disappeared suddenly. So we need to look at these indicators from a very careful way in terms of where the real transmission is going on. I will not talk about the health system because we have real doyens, legends in this panel who are the experts of health system. But I'll limit myself in terms of public health preparedness. The comment was earlier by Dr. Joy that the public health system was not geared up. I would ask a different question. Where is the public health system? Where have we invested in strengthening the public health system? All along, it has been for curative services and barely limited for some salaries of the peripheral health workers. If you look at determinants of health, where have we invested? I'll just give an example. The leading city corporation in this country spends 0.5 paisa on health and education put together out of 1 rupee that they spend on everything. In that 0.5 paisa, 99% is spent on salaries. Where is public health? My question is that, and that's my introductory remark. Thank you for giving this opportunity.
Thank you. Thank you, Dr. Babu. We move on to Dr. Deshpande. Dr. Deshpande, your opening remarks. You're not audible.
Yeah. Hello, everybody. I think by now it's very clear that this is an ailment which is here to stay and going to stay here for a long time till a vaccine comes in. And a vaccine is nowhere on the scene. So we will have to live in this particular thing. And the way we are treating it, the way we are handling it is maybe in acute phase, subacute phase, chronic phase, and maybe later on, and then restarting of many of the things. I think Joy already mentioned that, there was a kind of a initial paralysis. Though we knew what was going to come, we never thought that it will happen to us. Secondly, I think we don't have a very well-organized system of public health experts, public policy makers, people who can coordinate private and public health services. We don't have this integration happening because each one looks at the other person with suspicion, which is not the best thing that should actually happen in any kind of a system like that. We actually are almost like 15 to 18% of the whole world population. And if that population is not cared for, it's not catered for, then we have a problem. As somebody who actually is not directly dealing with infectious diseases or with COVID directly for a treatment, but an associated very, very major discipline in cancer, I can actually tell my problems as something. If we know, see, ultimately what do we have something to compare? We need to compare this particular thing with either the Spanish flu of the 1918, the way it happened. 1/3 of the world population was exposed to the Spanish flu by the time it got over just in 3 years. In 3 years, the whole 1/3 of the whole world's population, and it knocked out 10% of the world population. 10%, 5 million people in India died. 5% of India's population died those days because there was nothing except public distancing. There are structural differences in Spanish flu and this particular thing, but this is an enemy who spares no one. It spares no age, it spares nobody, but to some extent its ability to kill a person is pretty well, you can actually predict that. So just as one of our esteemed colleagues said, that identify that population which is likely to be subject to mortality. If you really analyze the data from Spain and Italy, most of the mortalities were after the age of 60 with comorbidities like cardiac problem, diabetes, which are uncontrolled, obesity, etc. So identify that population, segregate them, don't allow them to be exposed. By now, actually, this public distancing lockdown has shown that you can actually flatten the curve to some extent, which doesn't eliminate the disease, but it gives us good time to protect ourselves, prepare our health services to the same extent. The government says that it has prepared 1 lakh beds and maybe up to 6 lakh beds we can have for all these isolations. But what happened on day one? For example, anybody with a positive report was just put inside, and then he was told to stay put for 14 days. Today, I think we have changed. If somebody is asymptomatic, if he's got a test positive, you're giving him an option that, all right, you can go into home quarantine. And if you don't get symptomatic, which means that you need to have cells which will attend only to these patients every single day, find out if they're becoming symptomatic, and the moment they get symptomatic, get them into the hospital. Ultimately, only 1% of the patients are going to need ventilators. But if you extrapolate the data from anywhere else, that before, I hope that the vaccine comes, but what happens if the vaccine never comes? It means that till you get the herd immunity, and herd immunity is defined as more than 50% of the population getting exposed. Can you imagine the kind of magnitude that what we'll have? And we have a mortality of approximately 3%, and that is because we test a certain number of people and we don't test the rest of the people. If you say India's population, 60% of us are young, and if you exclude them altogether, out of the remaining 40%, if you say mortality is going to be, say, 10%, which is equal to 4% of the whole population. Now, even at 4% of population of 130 crores is an unbelievable kind of a figure. We can't just afford to lose that many people. But at the same time, we can't afford to actually treat that many people also. So what we actually need to do is we need to find out innovative policies where we can offer them kind of home care, pick up only those people who are going to be serious, and then probably put them into hospital. And when you look at into the hospital, let us not differentiate between government setup or private setup. Let us bring all the setups up to a basic minimal acceptable level at least. Let each bed have clean facilities, let them have good toilets, let them have good nursing systems. It may not be a 5-star facility, but long as a person can live, I think even the biggest billionaires will have no complaints if they get it and then if they survive. So I think that is how we need to look at this.
Very, very important point that the difference between the public hospitals and private hospitals should minimize. And that's what has happened with the developed countries, like, even as late as Singapore and all that, they all are similar. So we go to Dr. Sundaraman, if your opening comments from you, and then we'll go to Dr. Kunal Sarkar.
Yeah, okay. I spent a long time as Executive Director of the National Health Systems Resource Center, working with building a national rural health mission and community health workers. And I come in a lot on that perspective. I find that what we are seeing is we are at a phase where infection is rising. It's all right, doubling rate has come down and we can be happy with that. But if you look at the number of days we take to build the 10,000 cases, the next 10,000 is coming up much shorter and shorter time, which doesn't necessarily mean that but if you look at the RO figures, you said we are in a stage of mitigation. Containment is far, Elimination, of course, is out of the thing. So, in short, what we are likely to have is a much greater worsening. We are far from having peaked. We may not even have reached the halfway point of our thing. The disease is spreading, and again, the Spanish flu is a good example. It started off as a Bombay fever. It was the west and then the south, and then it goes into the hinterland. It takes longer time to reach the rural areas, but it's more devastating when it does. So at some point, we have to actually prepare for a much worse situation. The second thing I think I need to say this is that there is a huge as health workers, as health staff, as health professionals. This disease is somehow associated with a much higher health risk to healthcare providers than most others that we have seen. There's really no reason why whether it is TB or HIV, the public may not be aware of it, but we always know that health staff are at greater risk. But this is something altogether very different. It's much higher. And I think very few have realized that many of the people coming down with COVID are not seeing COVID patients. So it's not on the COVID-19 line of duty. It's very often when you're seeing general outpatients, and we have this myth that your transmission is very contained within known chains of transmission. But actually they are quite mixed up and you don't know it in the general population, and therefore they come into contact with people who are symptomatic or comorbidities. They're actually come for cancer or they have come for diabetes, and you are actually getting infected in a major way. When it comes to containment, my general opening comment is a public health approach has given way to a policing approach. The command is actually with the Ministry of Home Affairs. The thinking is the Ministry of Home Affairs. After 7 p.m., no movement. What happens after 7 p.m.? Does virus start circulating faster? Is there some particular danger? That's a law and order approach to it. The circular geographical containment, nobody can walk in and out. What you really need is a community engagement approach where identifying, tracing, quarantining, in some sense, the whole thing requires a far greater level of support from the community where they are actively. We had a major outbreak now. Everybody was surprised in the vegetable market in Chennai. To trace down their contacts is not a detective work. It's not a policing job. When people announce, people must come forward and report that we have got it. Look at it. And what's coming in the way? Fear is coming in the way. Lack of trust is coming in the way. Stigmatization of a very extreme sort. We've never had doctors being beaten up, their burials being it's a unique situation that we are having this sort of stigmatization. We're absolutely irrational in its stigmatization, fear and panic, which unless we are able to get hammered on, because it's purely been a policing approach and the public health part of it, the whole notion, even the subtext of our messages are impregnated with a whole lot of fear and anxiety. We don't quite realize it. When we say physical distancing is the only thing, nothing else will save you, you'll have to say that, look, you can get. So people, instead of being seen as victims of disease, the common people are being seen as vectors of disease. You're afraid, oh, the migrant, the other, whether it is of a community or whether it is a migrant, you're saying we must keep them at arm's length. Just imagine, if at the time when we had the lockdown, we had allowed all the migrants to go home. March 14th, what was the total number of cases reported in India? 100. At about the time of the lockdown, 400. If they had all gone, how many cases would have gone to other areas? How difficult would it have been to isolate and trace that many people within this? Today, if you send the trains back home, you are in each train going to have far more. Out of 1,200, not less than 100 are likely to turn up. Because when they were in these lockdown situations in quarantine places or in labor camps, the disease incubated there within that particular environment and has reached fairly consistent letters. This is again what I'm saying, that the thinking is led by a policing approach, and it is failing to actually see what really requires in terms of public health on that. And somewhere the ethical principle, if we had followed the fact that migrants have a right to go home, my job in public health is to see how I reach them safely. Now, my job is to find out ways in which the trains can be made safe. Why keep isolation trains? Why not test and send them on their way? You would have actually been able to solve it. I have not gone into disease preparation, but at some point I agree there has been an opportunity lost. But I don't think we had the health systems, infrastructure and thing. But at least we could have avoided certain critical mistakes, which is important because the worst is yet to come. And we can learn from our first few months and learn from Kerala and do some very desperately needed course corrections so that we are able to manage this with far less mortality than what we can manage it. Even now, it's not too much. I agree. The mortality is not too much. Let's only not be sanguine about it. Even see, the point which we know for certain is the lockdown will eventually have to go, and when it goes, the cases will increase. RO will go up. That's inevitable. But the point is, we must now get ready to face that thing. We can't be in lockdown. It's a diminishing returns. The number of TB cases is rising. Newborn deaths is rising. Maternal mortality is rising. We have predictions, modelings that show we are set back 8 years and we would be having so many more deaths per month. For every month of lockdown, we are going to have so many deaths. So we can't afford a lockdown under any circumstances. But when you lift the lockdown, cases will increase, and we just better get prepared for the new game. And it can't be by the Ministry of Home Affairs. Ministry of Health better quickly learn, and the clinicians do their job, but the epidemiologists do theirs. Thank you.
Thank you. Thank you. So we, it's a large implication that it's talking about that, Dr. Sundaraman is talking about that the much worse is still in front of us. So it's not, we had not gone ahead in the system, in the process. We still have a lot more to handle. So we come to Dr. Kunal Sarkar, your opening remarks. And you have a presentation.
Yeah, I'll just quickly show you a few slides of things which has been said already. You can see them, right?
Yeah. Yes.
Okay, fair enough. First of all, Dr. Sundaraman and rest of the presentations were so wonderful. The reason I have slides is not because you need to see anything. The reason I have slides is being a cardiac surgeon who's like 30,000 operations plus, my brain is not what used to be, that I need to remind myself. Right? Now, much has already been said, and especially the comments by Dr. Sundaraman were absolutely timely. And probably what I'm going to do is just put a few pictures on what he has said so passionately. Now, when we talk about epidemiology, the most reassuring thing is epidemiology in its literal translation does not mean the study of diseases. It just means a view from the top, right? So that gives half-educated people like ourselves to take a kind of view from the top and see and try to come to some basic understanding that what's been happening around us. Now, wait a minute, how do I get this thing to move? Oh, I've got to go to screen view first, right? Now, you see, one very interesting observation is, do feel absolutely free to refute me at the end of it. I've just formed a quick, it's almost like a Premier League football table. This is where India stands at around number 10, number 11. India's standing in the COVID chart is just a little bit down than our chart in the world GDP. It's much higher than our per capita GDP would be. But most interesting thing is that look at the countries at the top. We almost have dissociated outcomes in healthcare from affluence. So countries like, starting from US to all the European stalwarts with the most established universal healthcare, where even the last fellow in the village has got a GP ascribed to him and the rest of it, they have fallen like ninepins with absolutely appalling figures. And when we have a little bit of breathing space, few weeks or months down the line, we need to do a lot of introspection that what happened to it, why did organized universal healthcare fail so appallingly and as they did. That doesn't give India any excuse. I couldn't agree more with Dr. Sundaraman that, in India, when we were discussing preparation for the pandemic, we discussed the Imperial College model, the John Hopkins model and everything. We forgot to look at the Indian model. And because we did not look at the Indian model, we were unaware of the statistic that we have 3.5 crore migrant population in India who live not on a day-to-day basis, but on an hour-to-hour basis. Now, these indices have already been discussed. I won't waste any time on it. Just give you a very basic idea. As many of our speakers have emphasized, that we are still at the rising phase of the infection. What kind of curve do we preferably look at? We preferably look at the Kerala type situation, which is like an elephant's back or basically a plateau, which means we are not increasing anymore. But yes, I would echo what every one of you has said, that most of India is looking like this, which is a sand dune, which is like a concavity upwards, which is telling us the central message that the caseload keeps on increasing, and all of you have seen this case doubling time and all that. Now, I want to dwell few minutes, 1 or 2 minutes, on the testing paradox, because probably, like some of you, I have been very confused over the last month or so as to what should be considered an optimum strategy and an optimum number of testing. Now, as far as India is concerned, we have seen few interesting data. We have seen that states with the higher testing rates seems to have fewer fatalities. And in India, we seem to have, and internationally, we seem to see that if you tested more, it did not necessarily mean that you ended up saving more people. So somewhere, there lies a little bit of a gray area, because once again, probably the problem is that we are dealing with the disease which has neither a cure nor a prevention. So if we have neither a cure nor a prevention, the way Japanese tend to think right now is that you better go in for strict social etiquette and symptomatic control. Why the hell you pour a lot of money on? I don't know. We'll take the opinion from a lot of public health brains we have with us today. That what did they consider to be the optimum? Now, being in Calcutta, being in Bengal, we took a lot of flack. We are still taking a whole lot of flack. Look at where West Bengal was. This does not represent the per capita income. This represents the testing per million. So it is almost like the per capita income of Bengal. We are right at the bottom of the pool. We were testing pathetically low. Hence, we were still producing small case numbers. We still have 1,600, 1,700 cases to show for. And when vis-a-vis 1,600 cases, we end up with 150, 160 mortality, it looks abysmal. It looks 10% mortality and the rest of it. And like myself, many of us, we had to do a whole lot of advocacy, shouting, this, that, social media, etc. Because if there was ever a discussion on the Bengal model of COVID control, then the Bengal model was divided into two halves. In the first half, we controlled the doctors, and in the second half, we tried to control the virus, right? So in the first half, it was all ringa roses of Dr. A trying to control Dr. B, Association C trying to control Association D. And somewhere at the second week, we all woke up and said, look, there is a virus somewhere. So let's start do some testing and run after it. So from paltry levels of 100, 200 tests a day, it's a good thing. Yesterday, we did 4,000 tests. And therefore, our kind of denominator will perhaps start looking a little bit more substantial, not respectable, but substantial. So if there was ever a case study of the minimum possible testing in a pandemic, then probably we will get the prize, not that we are looking for it. So this is a kind of case positivity. Now, regarding case positivity in India, again, I wait to hear from the public health people at the second round is that to have a credible case positivity, we do have things like sensitivity, specificity, etc. But another important is the threshold level of testing. How many have we actually tested? Like I told you, Bengal's case, that we were testing so pathetically low that it made no sense to us. And I am told that if you followed Singapore's experience, then Singapore said something like, yeah, unless you test nearly 1% or 1.5% of your population, then till such threshold, your case positivity rate doesn't mean much. If that is the case, you see, at the beginning of the lockdown, India set itself a target of testing, by the end of the lockdown, of testing nearly 1 crore of people, or 1.5 crores, which is about 1% of our population. And till date, we have not even tested 20 lakhs. So we are far behind. It's looking very fancy on television. The graphs are looking very, very impressive. But somewhere, I think we have to have some sincere, honest idea that what was our goal and what did we start off to become. Now, why is this underachievement is testing even more important? I think Rupali and everybody will agree with me that India, for all its faults, was one country on the face of the planet which had mammoth capacity in private sector and testing in labs. And because of the crab-like control the government sector exercised on the private sector, till date, we have not unleashed even 10% of the pathological lab capacity we have in that sector.
Absolutely.
All we have is every 15 minutes, there is some person in my locality who is putting his hand up and saying, look, I have got one more fancy test, and not one of these tests have ever seen the light of day. What is the problem? We don't understand. We come back to, shouting at China and saying, look, your kids were defective, etc., etc. But what happened to our kids? What happened to so much of innovation? Everything has gone down the line. That has really got us very perplexing, and we are in this cycle of underachievement. We have fallen. If really testing was a core issue, we seem to have fallen far behind. Anyway, I won't waste time on the mortality. And once again, I'm indebted to Dr. Sundar Raman, who made such a compelling remark. He made a compelling remark that it was not a home office issue. This is exactly, we have thought, I think perhaps India's first instinct would have been to lodge an FIR against the coronavirus. And somebody would have told the police and the Home Department that the corona is not subject to CAA, NRC, or FIR. So these three terminologies does not apply to the corona. This took a few weeks to understand. And what is happening, again, I'm coming down to Bengal. In Bengal, Rupali knows, we've had tremendous difficulty in trying to control a few pockets of infection. The suburb of Howrah in Calcutta being an example. And why is it that? Because in places like Howrah, we had the places completely encircled. And if you had like 10% prevalence rate, and we could not separate that 10% wedge from that local population. We just kept them completely imprisoned over there, and the inbreeding of infection and festering of infection went on absolutely unchecked. And therein, I couldn't agree more with Dr. Sundar Raman that we've probably seen this toxic side of lockdown, because lockdown without detection, without filtration, without separation is a wasteful exercise. And again, I don't think we have flattened the curve tremendously well. Okay, fair enough, we gave it a try, we've got some time. Our rather cachectic Indian healthcare has probably got a little bit more time for preparation. When India talks about healthcare preparation, it is like, making a cachectic person look like Arnold Schwarzenegger in a matter of 6 hours by giving him parenteral nutrition. Such medical exercises are usually not very successful. And at the end of it all, I think we still are left with a lot of concerns in our hands, In the future, obviously, we've talked about normality, crowd, having huge, big crowds. Technology will disrupt us. A lot of industry will really disappear from the face of the earth. But probably, one thing, with people like yourselves, with people like Rupali, who are such a germane part of the industry and the association, the emphasis on healthcare should now be a chronic and a constant one, like what Taiwan has done. If, say, a couple of months later, we feel that the heat has gone down and we think, healthcare is a dirty word again, and we wrap up the folder and it goes into some dustbin, and we are back in that, 1.2% of GDP syndrome, I think, we will just go deeper and deeper into crisis. So I think these were a couple of points I wanted to make. And any other questions in the future round? Thank you very much for letting me have a few words with you. Thanks for the opportunity. Thanks.
Thanks, Kunalda. Thank you so much. As usual, your understanding of the situation, and of course your language and using of the, the words, how you, explain to us is always absolutely at the up curve, and you are there up curve. Okay, now we can understand that what we have lost some time majorly, which was our preparatory time during lockdown, which was supposed to look into the capacity of beds, we supposed to look into the PPEs, status of the PPEs, supposed to look into the testing. These majorly three areas. I think we have done whatever the way. I am not going into the quality part of it, but the number of beds is very large, and it has been said that we are just about using 1.2%, 1.5% of the bed capacity that we have created. That too also we have started putting in the patients in the early stages. Now we have decided that no, early symptoms, moderate symptoms can be at home, which would have been there from the day one, but we have now decided that yes, now the discharge criteria which came in only 2 days back in Bengal is saying that sick patients only be at the hospital and rest can be treated at home. But again, there is no solution for how you are supposed to be treated at home. We saw that video from, I'm sure all of us have seen that video from Dubai, which talks about that how do you take care of patients at home? If you are sending them home, then how are they supposed to look after themselves? How are they supposed to stay? What are the, how they are supposed to monitor themselves? And then if they need to come to the hospital. So all that, a home quarantine kit, a home isolation or a treatment kit is been sent by the Dubai government to everyone who's sent home. So we have not done something so far. Maybe we can put those ideas to them. And now that they have decided, Government of India, we have become like a the doctors are, and the entire health system is working on guidelines and protocols. The MHA and health department is giving us the protocols, and you are kind of sticking to it and doing it. And every other day, there's one more new guideline and protocol are coming in. And the confusions are, it was very much worse in the recent past. And then I think everybody is turning to be more knowledgeable with time, and it's becoming a little better now. So going forward, I think let's look at that. The one part is, of course, how we are going to operate in the community, what we are going to do, the containment and all the pointers that you all made in. And the other part is, of course, the health system and the hospitals. I think the hospitals have to move completely differently. The whole processes in the hospital has to change. And that pointer that healthcare workers at the forefront is scared, and they do not. They're still scared. And how they are supposed to be handled at the healthcare systems. I think the healthcare system has to change. Right now, I can share you my Woodland story is that we don't have COVID beds identified as such, but everybody who's getting admitted in the last after the 30th April circular, we couldn't operate the way although we knew that what we have to do, we couldn't. But now that with a circular you can operate, that everybody coming into the hospital are actually getting COVID tested. So after the average length of stay of the hospital, right now, my hospital, every patient who is admitted are tested negative. And if there's any positive, I'm moving them out to a COVID identified hospital. Again, there was an activity which happened only 2 days back, that again, people have started thinking, and the decision makers started thinking that What should we do? Again, they're asking the hospitals to increase their COVID beds and thinking that if something spike comes in, if the COVID numbers increase, what do I do in the hospitals? What do we do? And so they're actually requesting all the hospitals again to increase. And again to increase meaning, again, you are mixing up the hospitals. You need to have the COVID identified hospitals and non-COVID hospitals where all other patients do come in, which again has to put into screening areas and, again, creating isolation, put them into COVID testing and send them off to, if they're positive, then off to COVID positive hospitals. So we have to identify and separate out the health systems, which is the hospitals, which is what is still to be done. I don't think it is. We still have the clear picture that how we are going to operate our hospitals in the future, and it has to come very clearly. If it doesn't happen now, it will be even more mixed up, even more confused in the days to come. But I hope I'm a hopeful, positive person, so I think we will have to hope that thoughts will come in and more circulars will tell us exactly how to operate the hospitals, how to operate the community. So I go to, let's have a second round of thoughts. I will not get into, asking you in particular question, but with the way the thoughts are happening, let's move ahead, normally and naturally and get into the concluding statements from each one of you a little later. We'll take the questions in between and then go to the concluding statement. But going back to, again, I'll go back to all of you once again. So we'll start off with the same sequence. We can go to Mr. Rajiv Sadanandan and can hear your points at this moment. Mr. Sadanandan.
Thank you. Couple of questions. One is, we all know that when you're dealing with an epidemic, testing per se, if it is not according to a clear pattern, will just mean a lot more tests and not add to your knowledge of how well the disease is spreading. So maybe it's too late, and maybe Dr. Babu can weigh on this later. Before we can take a decision on what our numbers are like, what our case fatality rate is like, and so on. I think at least at this point, we need to have a reasonably good sampling frame so that we know what the numbers are going to be like. And then Dr. Sundar mentioned about the police state. What worries me is that what we have seen is that good responses have always come from decentralized decision makers. Now, it's high time that states are given the freedom to operate the way they would like to, rather than having a centrally driven kind of thing. Now, so then what will happen is that if you put in place a good central surveillance, you can decide how bad your situation is. And the government of India circular might say that you don't need to send people to hospitals. But a state like Kerala might decide that in order to prevent the further spread, it might make more sense to move them to a different kind of facility. These decisions should be left to local decision makers. Now, Dr. Bose, I'm slightly worried about the COVID positive, COVID negative hospitals. Unless we have a very definite method of identifying them, it might lead to problems, because as Dr. Sundaraman mentioned, a lot of your infections, a lot of the asymptomatic persons could still be transmitting the virus. And you know that in universal precautions, we always assume that any person who walks into your hospital
that's how it has to be. So everybody coming into a hospital has to be thought as a positive patient, and you have to treat them. Say, for example, when their patients are coming in for admission, we have created a full zone of isolation and admission screening zone. We are not calling it isolation if people get scared, stigmatized.
I'm going one step back. Going one step back. This is a time, I mean, the way I see it as someone who spent a lot of time in public health and has been kind of disappointed with the response that has happened in the past, and unfortunately very pessimistic about what will happen in future also. Mm-hmm. What I would like to see is to go back to the basics. And for what you mentioned, the real basic is controlling hospital-acquired infections. Now, rather than going into this segregation that you're talking about, is it possible for us to come back to hospital-acquired infection? I was in charge of Kerala Health when the Nipah infection happened. And when we went back from the learning from Nipah, what hurt us was that a lot of our infections actually happened from our hospitals. So what we did was that we went back to the whole, revisited the whole gamut of controlling hospital infections, and that's paying off now. Similarly about surveillance. Now, we have ignored surveillance. It's even worse, let's admit it. We have actually suppressed figures. We don't admit to the actual numbers of that, what should be there. We had ILI surveillance, we supposed to have SARI surveillance. How many of us ever did that? Now, is it possible to go back to those kind of basics and ensure that these are not forgotten as we go along? If that happens, then in spite of all the adverse things that have happened, like as I mentioned about what we did with Nipah, we improved the surveillance, we improved the hospital-acquired infection control. That is, and thirdly, if people run away from hospitals, what does it show? It shows that people don't trust government. How has that happened? How is it that the healthcare system has developed so much of distrust that people don't? Healthcare doesn't operate. You know that as a clinician, unless your patient trusts you, nothing is going to be effective. So how did we lose that trust? Can we go back to building that kind of a trust?
No, I think the basics that you're talking about at this moment will going back to basics may not be of course we have to, but the basics is the way the building block is and have to move ahead. But at the same time, I think this is a pandemic scenario where the cases are still up curve, and we have to, certain things have to be done as we should do. So we have certain guidelines which are, as we can see, the state governments, health departments, NMHA and ICMR, the departments at the top, and all of us clinicians have put together, have created these steps of how to counter the virus. So the one is the infective phase, and how do you control the case numbers, how do you deal with them, and the other is that how futuristically you have to create your health system so that nothing in the future comes.
You can guidelines are only guidelines. Why don't you let the local decision makers choose whether to use the guidelines or not? Aren't they wise enough to decide what is good for them? Let's leave it aside. We can cover that later. Now, the other part is about the private hospitals. Now, I think the private sector should be, if the private sector is providing more than 65% of the hospital care, there is no reason the private sector should be kept away from it. The problem is going to be what is the mode of engagement. Now, China had decided that all their cases would get paid by government. Is that what the government is going to do? Obviously not. Is insurance going to pay for it? What's the amount that will be paid?
No, that is both will be done. I think governments are going to pay for it, and also insurance. Isn't that right, Kunalda? It's the government is going to pay for the COVID hospitals, right?
You have an assurance on that? And yes. What are they going to pay you? What are they going to pay you?
According to their rates. You have to be on. Shuman, please make Dr. Kunal Sarkar on, the audio on. Suman? Yeah. Yeah.
It's on, is it? Yes.
Yeah.
A couple of points taking from you. Yes, the direct answer to your question is that the non-governmental insurances, which is like the general insurance, they have agreed that they are going to reimburse the costs at certain cost threshold levels. The second point is that the governmental insurances have already included it. But the problem remains, when it has already been mentioned, when you are doing with the other kind of treatment, which is, say, you are doing a laparotomy, a heart operation, that we've done more than 50 heart operations in this pandemic period, including a heart transplant. But the question remains that nobody has upfront factored in the extra costs. You're spending, a private hospital is spending at a mere average of almost 50,000 rupees extra per case on all the packages of disposables, protectives, everything going on. So that is a little bit of a gray area, but we expect it to be settled. I'll just make two additional comments. One is, I completely endorse the view that this attempt to segregate in India The attempt to segregate COVID positive and COVID negative hospital is absolutely artificial. And I would request all private hospitals who've still got their hands inside their pockets to bring them out and clutch the steering wheel straight away, because their resources will be necessary. The other very important point, Rupali, is that many of us who are in clinical medicine know that India has made some progress in quality assessment, like NABH, etc., during the peacetime. There is a lot of intellectual dishonesty when we are telling people that we have given 1.5 lakh beds for COVID and stuff like that. 70,000 of those 1.5 lakh beds would be like warehouses. You wouldn't even have a toilet per 10 patients. So can they be classified as treatment capacity? That's point number one. There was so much time and energy wasted on everybody, starting from a panwala to the billionaire, wanting to manufacture ventilators, not knowing that you don't want people to get ventilated in this problem, that less than 0.5% people were getting ventilated.
Absolutely.
But India has about 50 to 60,000 ventilators. We do not even have 20,000 doctors who can run a ventilator. So rather than artificially categorizing hospitals as COVID positive and COVID negative, hospitals should be categorized into the clinical severity. We are talking about on ground warfare now. We are talking about the segregation between infantry, artillery, and navy. We are talking about that where should the mild cases go, where should the moderate to severe cases go, if you want those poor people to get half decent treatment. There is no point pretending. So at a stage when we have quite good quality assessment mechanism, I for one was completely aghast. Any ramshackle shed you are putting up, you are calling that a hospital and putting patients in their livestock and barrel. I think that's an insult to the population.
Absolutely. And also the if that is so, then we are still now confused and we are still operating. We just announced medical college. We stopped the OPD. Such a huge institution. We have stopped everything and made it into a COVID hospital. That's another activity which has happened very recently.
I mean, look, you see we have a good number of people who can do quick quality assessments. So why are they in hiding? Whenever you, it is like assigning an army. You don't send an army out to the Pakistan border with hockey sticks in hand. They have to have proper weaponry to fight it. So these young boys and girls who are fighting in the front, they should be given half decent facilities to make a decent job of it, along with all the preventive activity and the number churning which is happening. Fair enough. So I think, I would want empowered association, houses of industries, and or associations of hospitals to bring it into the cognizance of the people that hospitals are not square foot areas. Hospitals are not just, a bed, a ceiling fan, and a toilet which is cleaned, once in a blue moon. A hospital means a treatment facility, and we better respect that as one.
So more definitions need to come out, and
absolutely.
as basic definition of as a
look
hospital.
at all the guidelines coming out. In a country where 9 people live in a room, the bureaucrat in Delhi is deciding there are 1.5 people going in a motorcycle. So if that is the level of micromanagement you are doing, fortunately they have not regulated other biological activities so far. So if that is the amount of micromanagement you are doing, we couldn't even grade or classify the capability of the hospital. Like you and I know, I don't know the rest of India. Many of the hospitals where we are shoving the dyspneic, the people with 50 PO2s and etc. in, it's not fair. It's not fair. That's what I'm trying to say.
Absolutely. Okay, so we move on to, can we have a comment from Mr. Sundarajan on how do you think the lockdown should close, or, it's just coming around. The May 17th is the due date to close the lockdown, and what will happen, whether it will what will happen and whether we should actually carry on the lockdown. People are thinking that it will go on till May 30th for the containment areas, which are 65% of the cases of India is within those particular few districts, which includes also the top metros of the country. What should we do? What is our thoughts?
So I'm going to make 3 or 4 purely technical points, but quick one-liners on each. First, to make sense of the testing, the real problem is denominators. So when you're testing symptomatics, what proportion of people with symptoms without contacts tested positive will give you a sense of the spread, the single best indicator. The second, you are testing contacts who are asymptomatic. And if you do secondary contacts and just random little contact from close contact, you're going to have a lot of people testing negative, which will also you add on to the testing symptomatics. Then you are testing high risk people. You are testing people whom you come to your hospital because they are, and you find 1 or 2 people there. If you add all these different denominators and the numbers, you have perfect confusion. You at least have to say the proportion of sample drawn from each area. Finally, random sampling will help, but it is a part of a sort of research level intervention monitoring. It's not for disease surveillance. You have to base it upon the testing of symptomatics. Now, the question about asymptomatics, the worry about it should not be overplayed. There is a certain issue, but the point is necessarily asymptomatics, there can be exceptions, tend to spread much less. But the second is also they are not health seeking. They are not going in search of care worsening, going from here to there, and therefore big spreaders. So as a rule, focus on testing and you will get a good number of the problems you will get. The rest we can take care of. The third point, I think we need to see the difference between isolation and quarantine. Isolation is COVID positive patients. I don't recommend home management, home isolation in the Indian setting, except for a very optional thing. Either one end where they are very old and dying in an old age home, or at some point very well to do. Most people, because of 2-3 reasons. Because they worsen and they become severe, a proportion of them, Italy lost a lot of cases because of that. Because they are spreaders in search of care, and therefore because as compared to asymptomatic, they shed a much higher load. So I think isolation, facility isolation is important, and Kunal Sarkar is quite right. At some point, you are talking of hospitals which are actually not necessarily intensive care, doesn't need ventilation, even a hotel converted, a hostel converted into a place where you keep them under observation. They could be at home, but for the purposes of isolation, you need to get them into a facility. Quarantine, on contrast, are by definition people who do not have symptoms. They are contacts. You are keeping them under observation, and if most of your positive cases come from within contacts, you are safe. You are already going towards the Kerala situation.
Isolation, yeah.
But if most of them are coming from outside the people, you are under observation. Never mind the definitions, it's community transmission for all practical purposes. And quarantine, therefore, is extremely different. That you can allow home quarantine where facility home allows that, but where it doesn't, community managed quarantines are possible and should be looked at when we expand outside the lockdown.
Okay, so
finally, one more point on the lockdown, if you don't mind.
Yeah.
Lockdown is a term that includes the restriction of the models. If you really look at the way the models goes, social mixing on 4 groups: social mixing in the household, social mixing in the schools and educational institutions, mixing in the workplace, and social mixing in the community. The community also can be subdivided: public transport, healthcare, etc. Actually, what they do in advanced countries is they have figures about the degree of contact that is happening there and from which particular pool the cases are coming. So you don't do geography. You don't say this 4 gali ko main band kar dunga, ye area ko band kar dunga. What you really do is to trace the chains of transmission, and you restrict those activities which are likely. So, for example, the Japanese allow public transportation. They have no problems. The Swedes allow schools, children in schools. They don't see a problem with that. In another place, they find actually there's a problem with that. Do we have such data? We didn't have such data. That was part of the problem of why we missed the migrants, other than the fact that we didn't think of the poor were an afterthought for us. So we did not. But if the moment we get that data, and mind you, I'm not at all an enthusiastic supporter of Arogya Setu, but potentially that's the only use the Arogya Setu can have. Because I don't think it will be a great thing for contact tracing, but it can certainly give us some better understanding of social mixing processes, which we can use to selectively when, where, what should we restrict. Has to be made on a scientific basis. Right now, we have total absurdities. The 7 p.m. is one absurdity. All your scooters and Ubers and all that is another. There are so many examples of how they are done. Nobody is even thinks they have to explain why they have shut down X and not Y. It's whims.
So I think it's just coming out from you is that we need to solve few solutions. I think one biggest solution is that how do we, when we open up the lockdown, how do you open up the public transport? What do we do? So that's one.
Take call, and you can take turns. Sometimes you could have schools and allowed this. Sometimes you could have opened that and done this. But it's not geographies.
I understand. Yeah, Kunalda, you wanted to say something on public transport.
And the others from the public health. What you made of this train business, starting intercity trains? Could we have your inputs?
The intercity.
Dr. Babu, why don't you say on the
trains? Yes, Dr. Babu, yes, of course.
No, I'm not going to talk about trains, but I was waiting for my turn, second round turn. So I had some points to make, but I'll mention about the trains because I think it is definitely necessary, at least for the migrants to reach their places. But anyway, I'm coming back to epidemiology where some of the discussion we had left unfinished. And this is how much epidemiology gets time even in public health discourses.
No, please go ahead.
So anyway, the first thing, case fatality rate. Currently, if you look at West Bengal, it has the highest, which is 9.6, followed by Meghalaya, Gujarat, Madhya Pradesh, and Maharashtra onwards. So now, the first thing we need to understand, as we move from the lockdown to the so-called new normal, our only goal is to reduce the mortality. How do we do that? So simply by expanding the testing, we are not going to reduce the entire figure. As earlier was told, the denominator doesn't go up. The denominator goes up only when you get the people who are infected and they turn test positive. In order to do that, you need to do syndromic approach. If I am simply increasing the testing, I'm not going to get as many positives. So this is the strength of Kerala. Tamil Nadu, which has the highest number of tests, as also have the lowest case fatality because they use testing coupled with syndrome-based approach. That shows how strong our surveillance system is. So as we move forward, surveillance is the most important thing as a guiding path for measuring how to reduce the mortality. Number one, how do we do that? We do by SARI surveillance and ILI surveillance. As I was discussing with the panel members earlier, before we started, many districts are not even reporting SARI cases as of today. Many states are not looking at SARI positivity for COVID. That's what we need to be looking at. But when you want to look at ILI and SARI, the healthcare workers are at the highest risk of contracting the disease. Therefore, PPE for healthcare workers is the most important thing as we move towards improving surveillance. Finally, 2 points I have. One is on this categorization of red, green, orange, and all that. I completely agree with Dr. Sundaraman, sir. Virus does not know these boundaries, circular or square. We can't limit the virus spread by these color zones. Instead, we should be strengthening surveillance in every district, and only district should be the unit. Finally, to touch on the asymptomatic, there are three groups of asymptomatic people. One, who are truly asymptomatic, who never develop the disease. Second, the pre-symptomatic, who will go on to develop the disease later. And there are people who are with atypical symptoms. So CDC recently expanded symptoms, including loss of smell, loss of taste. So therefore, if you are following surveillance through syndrome-based approach, we should also expand the criteria for case definition of what a probable and suspect case means. This is the only way we move forward of knowing what is the extent of transmission and how to measure the disease. Thank you for giving me the time.
So, Dr. Babu, I had one question for you. It said, should we go ahead with some definitions redone? When we were doing our close contact list, I checked on, it's about 20 days back or about 30 days back incident. Nobody could actually give me the definition of what is a close contact and casual contact. There was no guideline on that. It was as simple as that when you have to do there was no definition.
There is not in India, but there is a definition by WHO.
No, but Dr. Sundaraman, we have to have a definition in India when we are talking in India. We didn't have one. So we had to find out from Australia and New Zealand that this is how the definition is. That if you have...
NAS is very random. Yeah.
Dr. Sundaraman, can you hear me?
Yes. Yes.
I'll come back to the same question again. I'm a bit fixated with the trains business. That is it common sense to expect that in liberalizing the lockdown, you go from the center out to the periphery. We have started with the national inter-district travel first. How much does that make sense to you?
I'm not sure what you mean by national inter-district. We are seeing basically the one is the compulsion to return migrants. It's because
that is separate. That is separate.
Okay.
All these 30 set of Rajdhani Express light trains, which will be covering Delhi, Mumbai, Calcutta, etc.
So this is my advice, because my daughter is stuck somewhere and I want her home.
Oh, right. Okay. Yeah.
Don't take the Rajdhani. Take a non-AC open window train. And if you travel, the air conditioning is very dangerous for COVID virus circulation. If it's an open train with the windows open and the wind blowing, your chances of infection circulating within that is much, much less. You can see even in Kerala, if they looked at a study at the contacts which turned positive, many of them were infected within the air-conditioned space. Right. So I think you should actually have a nice, good old passenger trains, super roads. You are going to have much less than the Rajdhani. I'm worried about the Rajdhani, but you can be safe with the others. Okay. This is the fact. This is what I mean. I mean that they are releasing a pressure of people like our upper middle class, people who must be having families which you need to reunite. Okay, that's not a problem. But therefore, they prioritize Rajdhanis over a thing, and they're making a mistake. I would rather that she traveled with the thing, because the chances of infection are so much less.
Okay, so we go into some of the questions. I think I can see a lot of questions have come in. So we'll take one or two questions, and I think we just need to give some. So I think Dipankar Devnath, we can ask. He can ask the question to Dr. Panda, Dr. Deshpande, and can we open up Dipankar, who can ask this question to Dr. Deshpande? Can you do that, Suman? Dipankar?
Yeah, I have allowed him to talk.
Yeah, Dipankar, if you can ask your question to Dr. Deshpande.
Hello.
Yeah, go ahead. You're audible.
Definitely, one thing is there, that there is a huge difference between the private and the government hospitals. One thing is that people are getting scared by seeing the quarantine centers or what is the facility available at the government hospitals. There are in social media, many things are circulating and these things. People are fearing the quarantine and the hospitals the most. And another thing is, if a patient enters a private hospital, the economy part is a huge difference over there. So how can the private and the government collaborate in the same platform to bring this public health system in a better position, basically?
Okay, Dipankar, we'll just listen to the answer. We are muting you now.
Thank you,
ma'am. See, Dipankar, basically money is a reality. When a private hospital or a private center is actually investing in the healthcare, it actually is costing them. Maybe they'll be able to give away the profit margin or whatever it is, but whatever they are going to spend has to come from somewhere. Now, it can come from either a donation, or it could come from a cross subsidy. This is what actually happens. Many of these large private hospitals have taken a benefit of charitable trusts. So they have an earmarked number of beds which are actually maintained for these charitable beds, which can actually be used for these kind of treatments. So that is not so much of a problem. But that forms maybe 10% or 20%. The problem comes when a large hospital, a 350-bedded hospital, is expected to not only pay their people, but even to treat patients almost free. It is not going to be workable. So that is what is the problem.
So the answer is in the government setups, how they can give up.
Can I add here?
Yeah, sure, Joy.
Yeah. So in Mumbai, especially, we had first meeting with the government and between private and government in the first week of March. And since then, the government and private has worked hand in hand. And when I say hand in hand, I mean every day we used to have calls amongst us in terms of how to increase the capacity. And when we were working on that, I still remember it was asked that government hospitals should create 200 beds for the isolation. And as Dr. Sundaraman was talking about the types of hospitals, I want to give you a good example of what was adopted here. Here, all these isolation centers were divided into 4 different categories. The topmost categories were called as dedicated COVID hospital. So in that hospital, you have ICU, dialysis, everything available for a patient who is a COVID positive. The next category was DCHC, that is for dedicated COVID healthcare center. So there it is one step down. Similarly, there is a COVID care center used to call CCC. So depending upon infrastructure, there was visit by the government authority people, and then they have decided which hospital will fall under which category. That is the way the capacity has been increased. And coming back to specifically to Mr. Devnath's question that how the charges and all are getting levied, you may not be very happy to hear that government of Maharashtra has introduced a bill, and under that all private hospitals are supposed to charge even for non-COVID patient as per the government rate. And for the COVID patient, for the ICU, they have taken 20% of the ICU beds under their category, and that allocation of patient happens through the government, disaster management cell.
So basically, you are trying to say that there is some kind of Kunalda, you wanted to say something.
I think I'm trying to give a simplified answer to the question raised, which is, if you add the so-called normal corporate insurance, the CGHS, the ESI, the Ayushman Bharat, and the respective state health insurances, then that only leaves out less than 15% of the population who will not belong to any of these categories. So instead of filibustering for so long, what the government should have done is, in your regular expenses in an isolation bed, in an HDU type situation, etc., managing COVID, which has not ended up on the ventilator or something, is not a tremendously cost-intensive affair. All you are giving high flow oxygen, little bit of hydration, nutrition. That is all what the treatment. Currently, we've got one patient on ECMO, but those are outliers. So we would implore the government through all your agencies to come through an LCM type exercise whereby the mean expenses are decided. And like you can flip between Medicare and Medicaid and uninsured and VA in USA, you must utilize the Pandemic Act to give a carte blanche order that should somebody not belong to any of these stated categories, the government takes responsibility for subsidizing the person at these pre-agreed rates.
Absolutely.
So exactly what happened.
That is a far better thing to do than putting a person with a saturation of 45 into some warehouse with a ceiling fan. That is not justified.
And exactly, that is the result of that. Government has put a ceiling of the bed rents like 3,000 rupees for a isolation room in my hospital. So we cannot charge more than 3,000 rupees. So there is
Mr. Chakraborty, doctors in Mumbai are not at all happy with your capacity or clinical management. We'll discuss that story sometime later.
Okay, so we'll go into the next question, which is, I think we can take one more. There are a lot of questions, but I think we can take Oishik Chatterjee. Can you get Oishik Chatterjee online, Shumon? And can ask question to Mr. Sadanandan? Yeah, sure. Oishik Chatterjee, you can ask your question.
Hello.
Yes, Oishik, we can hear you. Just
Hi.
ask your
So
question.
I just wanted to know from the panelists, from the speakers over there, that for a hospital, for the dialysis cases and also for the surgery cases, how do we distinguish between whether to go for any screening test or not? Because many of these patients who come for dialysis or for the surgeries, they
Okay.
can asymptomatic carriers, and they can be so they can pose a threat to the
Okay,
hospital.
I'll give you an answer on that. I think I'll give you the answer. The dialysis patients, what we have decided now is as per guideline that you need to test them every 15 days. So twice in a month they need to be testing for COVID, because they do have chronic diseases and also have comorbidities. So you need to do them testing twice. That's one, to prevent, so that you know that if they're turning positive at any point, and take care. And the other one is pre-surgery. We have to also do, because pre-surgery is again a very large category of people where you have to do COVID testing before you get into elective surgeries. You have to get them to the theater. So you have to do a COVID testing before and find negative, and do the testing. If you find positive, also do the surgery, but you have to go for the testing. By knowledge.
Can I add one point over here?
Yeah,
which
Kunal.
is when if you're asking this question from a clinical standpoint, then you see, should you ever have a case where it is absolutely very emergent to have to do a quick surgery, you do not have the time for the positive whatever report to come back.
Absolutely.
The rule of the thumb is do a quick chest CT. And with the chest CT, I think all hospitals have been compliant. They have brought this video kind of film they do on CT, give you rapid sequences. A chest CT, for all intents and purposes, remains very sensitive, along with the RT-PCR that you are doing. But if you are in clinical surgical specialties, you must suspect every patient at the end of a night to be a possible positive. So especially during procedures like intravascular access, intubation, especially intubation, for every patient you must follow a specific protocol. The half of the inoculum load is coming during intubation, during that is why the anesthetists, orthopedic surgeons, neurosurgeons are getting affected, because during these aerosol generating steps is the problem. So in your own practices, in your own hospitals, make a simple, straightforward protocol that these procedures will have to be appropriately safeguarded, especially intubation, especially middle of the night orthopedic type of procedures. They must be properly safeguarded.
Absolutely.
Just one more point to add. In
Yes,
case of
Dr.
cancer
Deshpande.
patients, when we actually give any chemotherapy or surgery, we always insist for COVID testing. There's a very simple reason: is the morbidity and mortality rises tremendously, almost 10 times, if a positive patient is operated. Now, Dr. Sarkar said that he has also gone ahead and he was involved with the heart transplant. I think that is something which really needs a lion's heart to do these things. But I'm sure that he has a master setup at his command, and I'm sure that they'll have taken all kinds of things. But if I go ahead and do a lobectomy in a patient who's probably positive without my realization, he could have a mortality of 50%. So it is just not an acceptable kind of a situation.
Absolutely. So on the testing, I think we need these groups. The first is the category of if you have limited facility and we have to actually move up. This 3,600 in West Bengal, I don't think is enough. We have to do at least 20,000, but there has to be calculations. And the number totally in the country also need to go up. And the first category is, of course, the inpatient, all inpatient admissions in the hospitals. If you have to normalize the hospital activities need to be tested. Then, of course, your dialysis patients, some of your, all the procedures, the patients which are going in for procedures or daycare procedures or even endoscopies need to be tested. And then some of the outpatients and all healthcare workers at a I would prefer all of us healthcare workers at the front line to be tested twice in a month, at the gap of 2 weeks, like the way the dialysis patients are treated. If we have to do all that, we need a really large amount of testing facility. and everyone has to come up to rise to the occasion. All labs, I don't think they have all come out and agreed to do COVID testing. So a large number of testing facility has to go up. We have done a large amount on the bed capacity, although some of them are really of not the right quality, as Kunalda mentioned. But still, I think the bed capacity is still we have now kind of organized the PPE activity and the equipment and ventilators and all that. The third, of course, the testing, where I think we still have a lot of work to do. We still have a lot of work to do. And of course, the overall, the way we are managing is becoming better and more scientific. I think that's how we will close today's session. We have, it's 5:45, so I don't think we have the closing round session, unless we do just one sentence each one of you, and to close today's session. I think that's we will do. Let's do just a sentence from each one of you. Can we start with Dr. Babu for your closing statement?
I would say time is now not to just focus on testing, but syndrome-based approach. Use the strengths of India to make sure that we are able to successfully identify and then limit the adverse impact of it.
Absolutely. Joy, one sentence from you.
I think this is the time when private, public providers, they should join hand. And as you told about testing, that is not the only thing. At the same time, we are getting good number of patients who needs critical care, making provision for them. That has to be done hand in hand. And if we work together, probably soon we can see some, light at the end
of the tunnel. Dr. Deshpande?
Yeah, the powers that are involved state-wise should realize that it's not a matter of shame to have a large number of cases in your state. It's not a personal failure. Long as you are able to deal with those patients in a very humane way, try to reduce the mortality as much as possible. That increased testing should not be seen as a potential to cause a matter of shame for you. So I think we should not, somehow we get a feeling that that what data we actually see may not be the real data in the patient. So I think we need to be more forthright, and there's nothing wrong with it.
Absolutely. Dr. Sundaraman?
I think the main focus of mine would be to reduce the sense of panic and stigma around the disease. Get normal with it. This disease is less fatal than others. It's come new. It wasn't there in our reportage, but we are going to learn to deal with this one, but go about it steadily and humanely. Many of the things that have been done have been brutal. People matter. We work for them. It's not, we don't have to keep, they are partners in keeping healthy.
Thank you. Kunalda, your last words and we will close.
Well, my last word is, as we continue to be guided by our very, esteemed and brilliant epidemiologists, as a clinician, I would want all the clinical resources to be harnessed properly and coordinated, because it would be an extreme disrespect and disservice to our very pressurized, very anxious population to be, if we make them run from pillar to post at this stage, just seeking out the place where they could have a treatment at the right time. So let us get our act together, coordinate ourselves, so we can reduce the level of harassment for the people. Thank you.
So I think it's absolutely imperative that the lockdown will be at some point open up, and then we will start treating, as Dr. Sundaraman says, treating COVID as part of our lives. We start treating them in our hospitals. We start looking after our people, and no one in the country should be harassed or suffered. And all of us need to come back to our normalcy and not feel so scared and so much in panic. Thank you all very much. Wonderful spending time with all of you and all the panelists. Many thanks. I have been the biggest, I think the opportunity for me was the biggest. I was pretty unsure that whether I'll be able to moderate this big, experts, but we have had a good 1.5 hours time, and I'm sure all our participants have also been, they gained the knowledge from all of you. Thank you very much for being there. Thank you.
Very much.
Shuja, you want to do the last thank yous from ICC?
No, that's okay. Yeah. So you've already done that. So thank you, all the panelists, for your time. This was really, for all of us, a lot of information, a lot of knowledge. And Dr. Basu, thanks for being there with us during this. You've always been with us as part of the ICC Healthcare Committee. Thank you once again.
All the time.
And thank you, panelists. Thank you.
Thank you for having us.
Thank you.
Thank you. Thank you so much. Thank you.
Thank you. Pleasure.
Thank you. Thank you.